Hey, folks, if you want early access to episodes as they drop, click that subscribe button, join us, and together we'll fix the broken U.S. healthcare system. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Cober.
What is endocrinology?
And
how is it that 75% of counties don't have an endocrinologist?
Okay, so endocrinology my fellowship is in endocrinology, diabetes, and metabolism.
Mm-hmm.
So endocrinology treats hormonal diseases. So if there's something going on with your female hormones, your male hormones, your adrenal hormones like cortisol, stress hormones, growth hormone, really any hormone. Anywhere. Yep. So we don't have a specific location in the body. Thyroid hormone, that's my specialty. And then diabetes is considered a hormonal disease because the pancreas secretes hormones, right. Insulin, glucagon. So diabetes, and we deal with a lot of patients struggling with abnormal weight gain, difficulty with weight loss, obesity, those types of things as well.
Got it. And so covering so much ground, because you mentioned a lot of stuff there.
Yeah.
It's amazing to me that there's such a shortage, particularly with, it's no secret, right? This country having an obesity epidemic. Do you see that changing in the future? Do you see growth in this area of specialty and eventually getting to a place where the numbers are improving steadily over time?
Absolutely not.
Wow.
And because it's a game, right? So the laws of supply and demand don't apply in healthcare in the U.S. because there's no transparency in pricing. And so endocrinology, while perhaps the most in need, is the lowest paid subspecialty in medicine. And so why would a doctor who has tons of medical debt, unless they really love the specialty, spend the same amount of time to become an endocrinologist when they could become a surgeon or a cardiologist and make 3, 4, 5 times as much, and working the same amount.
Right.
And so I think that until the healthcare system rewards physicians for going into fields that patients actually need, I don't think we're going to see a major growth. What I am hoping to do is push the direct care endocrinology movement so that, because the other side of it is, okay, people might think that seeing an endocrinologist isn't even that valuable because in the current setting, being able to spend 5 minutes with your endocrinologist once a year may not be that helpful. It could be life-changing for a patient. It could be a matter of life and death for certain patients. But what people are really looking for is a relationship. And with chronic diseases like what we treat, that's what they need. And my patients do so well, but that's because of, yes, absolutely my expertise, but also the support and access and the time that we give them, which is really what enables me to deliver my expertise to the level that I believe I can. When I was in the traditional setting, seeing 30 plus patients a day, I just kept thinking, I have this beautiful gift. I know how to care for this person. However, what I do within 15 minutes within the 4 walls of this clinic is useless if they can't pick up their prescription because they couldn't get their prior authorization through, and we didn't hear about it because nobody answered the phone when they called, and I didn't know about it. So it ended up being that I just was giving my patients my cell phone number in the traditional setting, and it became very overwhelming very quickly because I had a lot of patients very quickly, and they couldn't get through to anyone they needed out, using the numbers and the ways they were supposed to. So, of course, they were texting me at all hours of the day and night, which I was okay with because at least my patients were getting care, but I knew that with time it would take a toll on me.
Give us an idea of, and I know this is a generalization, it's not going to apply to everyone, but would a typical, maybe type 2 diabetes patient interacting with the system looks like versus someone who comes into your practice. And and you track all of this, right? You shared with us, you have a spreadsheet, you do the work. What type of success do they see with you versus coming from, quote unquote, the system?
Yeah. So funny that you asked, because I do my own, I call it my reconnaissance work. So we have several employer partners now. So I have two companies. I have Complete Medicine, that's my direct to patient direct care practice. And then we have a company called Hey Healthy that directly contracts with employers. And so whenever we get a new client, I just kind of check out what the lay of the land is in that area when it comes to endocrinology. So we have a client in Central Texas, and I looked up their address, found the nearest endocrinologist to where their company is, and I called, saying that I was a patient that was newly diagnosed with diabetes. And I said, "Can I make an appointment?" Pretty straightforward request, I thought. And this was after waiting 45 minutes on hold, by the way. And most people would give up before even getting to this point, as they should, because that's ridiculous.
Well, you were working on your spreadsheets as you were on
Yes,
hold.
of course. I was working on something else. So then I called and I said, "Hey, can I make an appointment? I have diabetes. It was just diagnosed." They said, "No." And I said, "Oh, okay. Well, I have diabetes, though. And isn't this a diabetes clinic?" And they said, "Yes." And they said, "Well, have you seen your PCP?" And I said, "No, not yet. I was just diagnosed in the hospital." They said, "Well, you need to see your PCP and have a referral." And I said, "Well, I'm going to pay cash, so my insurance doesn't require me to have a referral. So can I just make an appointment? I'd rather see a specialist." And they said, "No, even though your insurance doesn't require a referral, we need a referral from your PCP, and then our team will evaluate that referral, and then we will let you know if you can have an appointment with our doctor."
Oh, that sounds highly efficient and compassionate, by the way.
And I said, "Well, I have diabetes. Isn't this a diabetes clinic?" And they were like, "Yes, but we still have to assess your referral from your PCP." And I said, "Okay, let's say I get my referral from my PCP tomorrow. How soon will I be able to see that endocrinologist?" And they said, "In 5 months."
Oh, my God.
So can you imagine if, let's say, the PCP has a 3-month wait, the endocrinologist has a 5-month wait, the patient has to go through all these hoops to get to the endocrinologist, and then at the end of the day, they get 15 minutes with that endocrinologist after waiting 3 hours in the waiting room?
That's insanity.
People aren't going to do it, and why? People have lives. It's not like they just have to live and die for their doctor,
Right.
And so that's what it's like in a lot of parts of the country, sadly. And
how does it work with your practice?
so in our practice, the patients either they find us online, send us a text, and we'll get them in the same week.
The same week.
Yep. And their labs are included. They get quarterly visits with our dietitian that are included. And we try to make it as easy as possible, remove those barriers. And we do everything virtually now. We used to be in person before pandemic. Then we switched to virtual for obvious reasons during the pandemic. And then in 2021, I moved from San Antonio to Houston thinking I would have to restart my practice. And I was like, I did it once, I could do it again. And then none of my patients left me. They were like, "We've been doing virtual for the past year. Why would we change anything now?" And so, and that actually is what spurred me to recognize that we could work with employers in areas that were severely underserved. So we've taken care of people in Del Rio, Texas, which is like border town. It's 3 hours away from San Antonio, like
civilization.
Yeah, really out there.
Right.
Now we're in a few different states. Oklahoma is a very underserved state, so we are able to virtually take care of patients there. And a lot of our patients are like teachers, really busy people who don't have a lot of time to invest in their health. And so we're able to talk to them from their home or their office, their classroom, their car, wherever they happen to be. And our clinic runs on time. Maybe a patient has to wait 5-10 minutes for me, but they're at home, they can do something else. But usually we're very on time. And with diabetes, we have a lot of technology, pumps, continuous glucose monitoring systems that we can actually much more easily access from virtually, because in the traditional clinic setting, you have like an MA or some staff member who's supposed to download that for you, print it for you, and give it to you for your patient visit, which sounds simple enough, but probably 7 out of 10 times they couldn't get it downloaded. The printer wasn't working, like silly technical stuff.
Yeah.
But now I have my list of patients in their cloud portal. And then when the patient is in my, virtually with me, I have a dual monitor set up. I just open their pump or their CGM. I can look at it in real time, same time. They can connect in real time if they haven't connected already. So it's actually much more efficient than the traditional setting, while also being much more convenient and comfortable for the patient. And
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.